Afternoon, everyone. Thank you for coming to today's webinar. We have Dr. Rani Khatib and Professor Derek Connolly discussing the findings from the recent ESC Congress in London. If you have any questions, please put them in chat because we have muted the microphones and turned the cameras off. This session will be recorded and will be up on YouTube in about a week's time as well. So I can send the link out to everyone then. So I will now hand you over to Dr. Connolly and Dr. Khatib.
Thank you so much, Jess. Hi, everybody. We're going to have a bit of a discussion around the main highlights from the ESC Congress in London. Both myself and Derek attended it and enjoyed the science and the networking and all the practice-changing guidelines and science that was presented. So we're just going to be bouncing the ball and discussing what our highlights. That's my slides. I'm going to ask Derek to share his, and then maybe we'll start with yours, Derek, and then I'm happy to jump to mine once we discuss your bits.
Fantastic.
So, over to you.
Great to see you, Rani.
Good to see you.
Can you see my first slide?
Yes.
Fantastic. So for the audience, just to put it into context, the European Society of Cardiology meeting, annual conference, is the biggest meeting in cardiovascular medicine in the world. And I've heard various numbers, but including the online audience, it was over 35,000. That's what they're thinking at the moment. It may get towards 40,000. So it is ginormous. If you've ever been to the Excel in London, and I go a lot to give talks, as I'm sure you do, Rani, I've never seen it so full other than at the Olympics in 2012, which is what it was built for. Is that fair?
Absolutely. It's you could feel it when you were there, and the atmosphere, the numbers, always wonderful. Always enjoy it.
Yeah. It was fantastic. And as you say, all of that connecting with people was brilliant. So you could choose 400 papers from this summer's meeting, but I've chosen 5, and I know you've got a few as well. There weren't that many overlaps, which I think is really important. These are my disclosures, but be aware this is not sponsored. So everything I say, I absolutely believe. That I say anyway. Every talk I give, I absolutely believe. One of the first things, one of the big questions, and we were looking forward to this, was the ABBAS study from France. When someone has a heart attack, we put them on beta blockers. But these days with primary angioplasty, and I set up one of Europe's first primary angioplasty services, and it's phenomenal because the normal now in my secondary rehabilitation service is that the patients have normal left ventricular function after their heart attack. And the question is, would beta blockers work? We know beta blockers work in heart failure, but would beta blockers work in people who are a year post-infarct or more, who have normal left ventricular function? And everybody speculated and said, yeah, there's no point in giving them. And then on the other side of the fence, if you remember from the heart failure studies, my friend John Cleland did a very important study where he took people with heart failure with reduced ejection fraction who had improved ejection fraction, and he stopped the drugs in half the patients, and the ejection fraction went down again. So in heart failure, we don't discontinue the drugs. What would we do in patients post-infarct? So the French tried to do the study. You can see here, it was a randomized non-inferiority trial in 49 sites around France, 1-to-1 ratio, randomized to continuing the beta blocker or stopping it. All of the patients had to have an ejection fraction over 40%, so not heart failure with reduced ejection fraction, and they had to be free of a cardiovascular event in the previous 6 months. And as you can see, the primary endpoint was a composite endpoint there of death, non-fatal MI, non-fatal stroke, or hospitalization for cardiovascular causes. We call that 4-point MACE. And the longest follow-up, the minimum was a year, but they had beyond that was the plan. And obviously, they were also looking at quality of life. One of the theories was that there would be a difference in quality of life. So in the end, 3,698 patients underwent randomization, so about 1,800 in both groups. The median time between the last MI and randomization was 2.9 years, so slightly further than anticipated, and the median follow-up was 3 years. And you can see there that a primary outcome event happened in 432 patients who had their beta blocker stopped, 384 in patients in the continuation group. The difference there, risk difference of 2.8 percentage points, and the confidence levels there are showing the overall risk was 1.16, so the p-value was 0.44 for non-inferiority. And importantly as well, the beta blocker interruption did not seem to improve the patient's quality of life. So numerically more events when you stop the beta blocker, no improvement in quality of life. So in conclusion, they said that in patients with a history of myocardial infarction, interruption of long-term beta blocker was not found to be non-inferior. That is a great way of saying it was superior to carry on the beta blocker. So what did you think of this, Rani?
I mean, the the fact that it was not non-inferior, it gets people a bit confused.
Yeah.
It's non-inferior, but it's not non-inferior. And then you ask you do ask the question of that, does that mean it was superior? And then given the fact that it was designed to look at non-inferiority, in the world of trials, like non-inferiority is not like superiority kind of, I felt it's like reassuring. But at the same time, I just felt, I wonder if it's driving towards thinking more personalized, because there are many patients who probably will benefit from continuing and personalize it to continue. I think it is probably case by case and thinking, rather than stopping completely or continuing completely, just see if there's any reason. And I appreciate that said, quality of life was no different. But we know from our practice that some patients do suffer from side effects from beta blockers, where then you could say, could this be a case? And if somebody's blood pressure is well controlled with beta blockers, should we really be stopping it? We shouldn't really. So I think probably some of the elements highlighted in here should be taken into account when we're making that decision. That's how I felt about it.
Yeah, and my feeling is, if I've got someone who's stable on a beta blocker, it's also an antihypertensive, I'm not going to stop it. If they come in, and I do this, if they come in and their LV is good or not significantly reduced, I'll probably debate in my head whether I should stop it on an individualized basis. Just be aware, though, there are more studies coming, so we'll get bigger numbers, we'll get a meta-analysis, and at the end of the day, that will tell us what we do next. Okay, give me 1 second, Rani. There's someone banging on the door here, so we'll just see what's going to happen.
That's okay. I'm happy to discuss this next slide, which is Derek is talking about, which is the edoxaban. Now you're back. So do you want to take over?
Sure.
So it's about edoxaban, yes.
Yeah, absolutely. So one of the big questions we have is what drugs to give patients after they've had their acute coronary event. So we know from trials like Augustus with apixaban that if you give aspirin for a short period, up to a month, but you give clopidogrel for 6 months, after that, the European Society of Cardiology says that you can stop the clopidogrel. But people were still complaining that trial's not perfect. There was a trial from the Far East called AFIRE with rivaroxaban, suggesting that the aspirin would give additional benefits. And I've heard lots of arguments that we were doing the wrong thing. So this is a study looking at edoxaban in patients who were stable and whether they should have 2 drugs or whether they should have just the DOAC alone when they have atrial fibrillation. So atrial fibrillation, when they're stable, not in the first 6 months after ACS, would you give them just a DOAC or a DOAC and an antiplatelet drug? So if we look here, this study, this is the AFIRE study, the one I've mentioned already, and you can see for efficacy, that is stopping cardiovascular events, that rivaroxaban monotherapy in that study was better than combinations of therapy. And if you look at the safety point, that's ostensibly bleeding. In the AFIRE study in the New England Journal back in 2019, again, rivaroxaban monotherapy looked beneficial. So most of us in the field were just giving the DOAC, but there were still the people who thought that this wasn't the right thing to do. So here we've got another trial here. This is a trial, it's an open label trial, but it's edoxaban as monotherapy or edoxaban with a single antiplatelet drug. And you can see that the primary outcome was a composite of death from any cause, MI, stroke, systemic embolism, unplanned revascularization, and major bleeding or clinically relevant non-major bleeding at 12 months. So exactly what you want to know, with several secondary outcomes, as you can see as well. 524 patients in the edoxaban group, 516 in the dual therapy and antiplatelet drug with the edoxaban, largely aspirin. And at 12 months, you can see here, the primary outcome happened in 34 patients on edoxaban monotherapy and 79 patients on dual therapy, highly statistically significant. And that was mostly driven by bleeding. There was a very similar event rate when it came to ischemic events, but you can see there that major or clinically relevant non-major bleeding occurred in more of the patients. So I think for me, this is suggesting that we probably should just stick with after 6 months with the DOAC therapy and not give an antiplatelet drug. What do you think that tells us?
I think it's interesting in the discussants when they were discussing this trial where they said, yes, there is still concern whether to stop dual antithrombotic therapy in patients with stable coronary disease who need oral anticoagulants such as in AF. It seems to be, it should be the other way around. And they seem to think, and this truly so, is like, what is the evidence of actually being on dual antithrombotic therapy in somebody in this scenario? So the default should be actually a single antithrombotic therapy, in this case, edoxaban. So it kind of reinforces, the trial reinforces the stance of the guidelines, because the ESC guidelines, the HA guidelines all recommend that you switch to monotherapy, mono antithrombotic therapy. And I think if we don't do that, we're likely to get probably over-treatment and potential harm by the look of things. And this trial basically backed it up.
Yeah, and I think I still see patients that are on DOAC and antiplatelet therapy several years after the stent or their acute coronary syndrome. So that is something we can quickly database check and make sure that we haven't got patients inappropriately now on this. And I think with the AFAR study, with this study, we now have clear evidence, both New England Journal papers, that you're right, the European guidance is right, and we should just go with DOAC therapy alone. And I know there are still people who think this might still be wrong, but we now have a large amount of evidence that suggests it's right. So I'm sure the European Society of Cardiology got the guidance right originally, and it will continue to be the guidance in this case. So
more deprescribing, I guess. So that's good news for deprescribers.
Absolutely. Well, when you consider, when you come to see me post-infarct, and with you, Rani, the truth is, if you've got diabetes, you might end up on 12, 13, 14 therapies post-infarct. So if I can cut down on the tablets, it's a good thing. So it is generally the other way around. I'm adding things in to try and get the cardiometabolic risk down. So yeah, that was that paper. Let's talk a bit about heart failure. We all know about the 4 pillars of heart failure. So that's ACE inhibitors, angiotensin receptor blockers, beta blockers, sacubitril valsartan, and MRAs. And MRAs historically, of course, were spironolactone and eplerenone. And we know that in reduced ejection fraction, you very quickly want to get all 4 pillars in and then titrate them up probably as an outpatient through the STRONG-HF trial. But in heart failure with preserved ejection fraction, that's an ejection fraction above 40%, the question is what therapies you can use. Recently, of course, we've had dapagliflozin, which works throughout the spectrum of heart failure. If you've got a raised NT-proBNP, in patients with more preserved ejection fraction, it tends to reduce hospitalizations rather than mortality. But that is an important factor, because being hospitalized for heart failure over the age of 65 is the #1 reason to be hospitalized in the UK. So what about spironolactone? Well, this was the trial. It's 10 years ago now, the TopCat study. And the TopCat study we all thought was going to be positive. And it was, as you can see, officially negative in the New England Journal of Medicine. And the p-value was 0.14. So they missed it by a bit. And interestingly, and this is post-hoc analysis, if you took out certain countries where perhaps the data wasn't as clear, this was a strongly positive study. So we've always felt that maybe we got that one wrong, but we haven't been using MRAs. It doesn't have a nice guidance to use in these patients. So it would have been nice to have more data. Now, the beauty of science is we've now got the non-steroidal MRA finerenone. So finerenone was used in exactly this group as we might historically have used spironolactone or eplerenone. Finerenone is a non-steroidal MRA, which we know works in diabetes and kidney disease and has a nice recommendation there. So this was a double-blind placebo-controlled trial in patients with an EF greater than 40% and raised NT-proBNP to get finerenone or placebo on top of standard of care of therapy. And as you can see, it was a combination endpoint. And so the median follow-up was 32 months. There was 1,000 or more primary outcome events in the patients, reasonably big numbers of patients. And the p-value there you can see was highly significant towards benefit in the finerenone group. And the vast majority, of course, was reducing heart failure episodes as we would anticipate. And if you look there for mortality, there wasn't a significant difference in mortality. So the finerenone looks like, as you would anticipate, with the dapagliflozin, that it's reducing hospitalization. I've used a lot of finerenone. You can get hyperkalemia, and there was an increased risk of hyperkalemia with the finerenone. So again, this suggested benefit mostly from reduction in heart failure episodes, but officially in the primary endpoint over placebo. So I'm sure the manufacturers will look for a license in this space and are likely to get it. Just watch out, though. Our friends in Germany obviously wanted to replicate TopCap, but they're doing a study funded by their cardiac society, but not by pharma in Germany. Spironolactone is very much generic and cheap these days. They're doing effectively a TopCat 2, but in Germany. And hopefully they're about half recruited. This might show us that spironolactone works in this group as well. But we have to wait and see. But certainly it does look like we've got another therapy on top of dapagliflozin for empagliflozin for patients with preserved ejection fraction. What did you make of all of this, Rani?
I think it's quite exciting. We have another drug where we've originally licensed for use in CKD, diabetic CKD, and now it's showing benefit in heart failure. And we're moving to test it in all different scenarios of heart failure. Of course, the Fine Arts reported had other heart failure studies still underway, which haven't finished yet, and they're coming. It was interesting also the meta-analysis that was presented for Fine Heart and also the MRAs in general. And the meta-analysis, which was for finerenone, basically in cardio kidney metabolic conditions, the meta-analysis looked at the Fidelio DKD and Figaro DKD trials. And they combined all the data, and it was interesting that finerenone overall, when you combine all the data, seems to do well in reducing cardiovascular events and kidney outcomes in patients with CKD and type diabetes. And in one trial, of course, in patients with heart failure with mildly reduced or preserved ejection fraction. So I think we're heading towards probably adding another pillar to the management of heart failure. I know there was hyperkalemia associated with finerenone, but it was interesting that I know it was in head-to-head trial, but the prevalence of hyperkalemia in the finerenone studies were not as high as the spironolactone. And of course, the finerenone molecule has got CKD benefit, and we know CKD is quite prevalent. It further adds to the new direction of thinking cardiorenal metabolic. So again, the interplay plays there. So I think it's really exciting times.
Yep. And yet another tablet I can start in my clinic, just pointing this out. Professor of Polypharmacy. Okay, let's go on to my first love, your first love, lipids. So just to remind people, a couple of years ago, Koshre, I, and others published this in the European Heart Journal, suggesting that if patients were of high cardiovascular risk, very high cardiovascular risk, we should treat them straight off with ezetimibe and statins. We'd shown in previous studies that you weren't going to achieve target with statins alone. With the new targets, ezetimibe now costs £10 a year. atorvastatin's £10 a year. So for £20, you get 65% reduction. And then we said, check it again quickly. 4 to 8 weeks is what we do here at Birmingham City Hospital, and have a low threshold for adding in additional therapies. So our friends in Sweden went to their database. They've got this phenomenal database, and they looked at what happens if this was done. Kosh was a co-author of this and was very excited. So we're talking in a registry study, 56,000 patients, as you can see, were included in this, with the primary outcome being traditional MACE, 3-point MACE, that's cardiovascular death, MI, and ischemic stroke. And you can see here that the patients were followed up for 5.4 years. This is big data, albeit observational data. And the key thing here was, did the patient initially, after their event, achieve a low cholesterol, or were they just a bit reduced? And at a year, so 2 months, were they reduced a bit? And at a year, did it stay reduced, or had it become reduced? And if you look at the graphic at the bottom here, you can see what happened. So patients were divided into those that did have a reduction because they were usually started on a statin, and then it stayed static at 1 year in purple, but they weren't achieving the target. Those that achieved the target initially, but it rose during the year, maybe non-compliance. Those that didn't achieve the target in the first 2 months, their therapies largely were increased, and then they reached the target. Now, if you look at the right there, Rani, you can see using the baseline of never reaching target in purple versus the MACE rate for early but not late achieving the target, late but not early achieving the target, but then early and sustained in that beautiful turquoise color had the biggest benefit. And this backs up what we've been saying for some time, which is go in heavy with ideally atorvastatin and ezetimibe. And if patients aren't achieving target, use all of the other things we have in an armamentarium. So in the UK, that is PCSK9 targeted therapy with inclisiran or the monoclonal antibodies. It is bempedoic acid as well. So again, this is a verification of what we thought was the right thing to do. My friend Maciej Banach has also produced a paper for this in Poland, showing very much the same. So the bottom lines is this challenges the fire and forget, and it suggests that we should go in early and we should repeat cholesterols. And if the cholesterols aren't there, we should go in deeper again with additional therapy. So I'm just going to make an advert for you. Here's your NHS England national guidance. For those on the contact call, if you haven't seen this, this is fantastic. Rani updates it regularly. Green is primary prevention, red is secondary prevention. This is based on the NICE guidance. And as you can see, all of the things that we've just talked about are there. And I can absolutely tell you, having spoken to Helen Williams about this at the European Society, the government are keen that we use more ezetimibe, that we use more high-potency statins, that we use other drugs such as bempedoic acid and inclisiran, because they know that it's massively cost-effective. So, Rani, what do you think about all of this?
I think our approach to lipid lowering needs to be more realistic and pragmatic. We've been saying for a long time that the earlier, the lower, the better. And the evidence for that is quite conclusive, cannot be disputed. And therefore, we just need to do it. And to do that, the earlier, the lower, the better, we probably need to have definitely combination therapy. And we need to go in with as many combinations as we can to do it.
Yeah, the full armamentarium, I think is really important.
Absolutely.
And I think, you know, we published some of more data from our Santorini study at the ESC, largely around women. Women, by the way, get a rough deal around Europe. But this was quite exciting in a way, because our baseline data suggested that 1 in 5 patients in Europe were at target. We also showed that around Europe, 1 in 5 people were on nothing despite being very high risk, as you can see from the graphic. We've reduced that down, you know, all these talks. If someone's got blood pressure and you put them on 5 milligrams of amlodipine and they get ankle swelling, you don't just stop the amlodipine, you give them something else. Exactly the same is true in lipids. If they really can't or won't take a statin, give them something else. And you can see here, we've really reduced that around Europe, that we're now getting far fewer patients in this study group that are on no lipid-lowering therapy. And we have increased people getting from the target, if you look at the right there, from about a quarter and just under a quarter, and 1 in 5, we're getting to target. But now, particularly if you use combinations of therapy, and combination therapies are rising, about 1 in 3 are getting to target. And it's generally the people that use PCSK9 targeted therapy on top of cholesterol synthesis inhibitors, that statin and bempedoic acid, they get to target. So certainly we are there now. There is no doubt whatsoever that we're making progress, but we need to keep going, and particularly in the UK, where the fire and forget with monotherapy is still sitting out there, even though the evidence is that it's not the right thing to do. What do you think about that?
Yeah, it's the way forward, and you can put the slide of the small molecules are interfering RNAs. It's probably the future, and I think that the challenge is that you need to plan it, and you need to do it as early as possible so that patients can benefit. I need to support patients as well with adherence, of course, and in order to sustain the benefit, people need to continue to be either swallowing their tablets or having their injections in order to sustain that benefit.
So small interfering RNAs, I was really excited because obviously 3 years ago we launched inclisiran in the UK as part of the NICE program, and it's doing well. It's now established. We know around the world 500,000 doses have been given, and we're not seeing any major adverse events we're worried about in the large registry studies. So that's great news. But also that paved the way, because that technology, the small interfering RNA, stopping a specific protein being produced by the liver, can be used in anything. So there are 100 different small interfering RNAs in late phase 2 or early phase 3 trials at the moment. There are several of them on the market, as you can see. And Eric Topol's published recently that there are 500 of them in some form of development. So I think this is here now. It's going to be used in a lot of different medical fields. And we were seeing that at the European Society of Cardiology. Obviously, in cardiology, we've got the drugs that block blood pressure. We've got inclisiran that blocks LDL, which is very much being used. We've got drugs coming potentially to inhibit lipoprotein A. So what about other uses? One of them would be in amyloidosis. Amyloid heart disease is a horrible, horrible disease. And as I'm sure everybody's aware, people get this misfolded TTR protein everywhere. It goes everywhere. It can go into the nerves and cause neuropathy. If it goes into the hearts, it causes a dilated cardiomyopathy. There are two types. There's the hereditary type. So if it's in your family, that's because of the gene abnormality. There's also the variant or wild type ATR, which is the wild type ATR, which is the one which there isn't a genetic abnormality, and it seems to be something you develop as you go on through. But both of them do the same thing. You basically get lots of the TTR in your tissues. And the question is, can you inhibit it? Now, you all know that historically we had tafamidis, which we're using, which stabilizes the TTR tetramer so that it doesn't form these big complexes in the heart muscle. And that's certainly very useful and is being used and has improved survival rates in amyloid heart disease. But what about using the small interfering RNA to block production or reduce production of the TTR protein in the liver? So very important to do this study. We know that tafamidis works. So does it work with tafamidis? Would it reduce the effects of tafamidis? Would you see benefits? So this is the name of the small interfering RNA, vutrisiran. It's subcutaneously administered exactly the same way as inclisiran is measured, and it does show a big reduction in the TTR protein. So this was very exciting. So if you look at the overall population, you can see that it improved survival rates, which is great. And if you look at it as a monotherapy, those not on the stabilizer, tafamidis, again, it showed benefit, and it worked whether you were on tafamidis or not, which is great news. So this is an additional benefit from a disease that, I've seen a lot of people die of over the years. We now have 2 different therapies which we can use in combination. Combination seems to be the word of the moment, but in combination here to improve the prognosis. So that was very, very exciting, Rani. It does show yet another small interfering RNA working with no major adverse events, which is good. We'll see what NICE say, but I would anticipate that this will have a benefit. It's sort of the sort of benefit we see in oncology for many drugs, and it's quite simple to give as well. So what do you think?
Absolutely. I think we see a rise. I mean, this is fantastic and giving more hope. If we think back on our options for managing ATTR is really limited. Now it's growing and we're having more and more therapies and having small interfering RNAs which are administered subcut for like, 3 or 6 months or once a year, or probably in the future we're going to have something that we can administer like once for all. Is fantastic. I think this is really good. We have more in our armory to challenge these
Yep.
conditions. Absolutely.
And it's again showing us that the small interfering RNA technology is here to stay, and I'm sure there's going to be used in lots and lots and lots of cardiovascular conditions. So this is my summary of my top 5 before we go on to yours. The first is probably don't stop beta blockers post-MI. But again, we've said it, individualize the patients. If they're truly having side effects, for instance, heart block, you may have to do it. But don't routinely stop beta blockers post-MI in patients who don't have reduced ejection fraction. After the first 6 months, because you do need dual therapy and some triple therapy based on the Augustus protocol after a stent or an infarct. But in the longer term, at least 6 months out, you probably, in patients with AF, only need DOAC therapy. You don't need an antiplatelet therapy on top, backing up the current European guidance. Non-steroidal MRAs are here now for HFpEF. Well, when I say here, we'll have to go through the licensing and then the NICE process, but I think the likelihood is that they will get a license for this, and we'll see what the SPIRIT trial shows with spironolactone. I think quite clearly, and you and I have said this for years, combinations of therapy in lipid lowering, like in diabetes, like in blood pressure and heart failure, are the new normal. You please use all of the armamentarium. And I think the last one is small interfering RNAs are going to be everywhere. We're all going to be using them. And I think that's very exciting. So I'll stop my slides, Rani, and let's go to yours.
Yeah, thank you so much. If anybody's got any questions, please feel free to put them in the chat or the Q&A, and we'll have a look at them as we go along. So just sharing my slides. So some of my slides relate to some of the papers you've already covered. So I'm not going to dwell into the ones that you've already covered. But you talked about the ABBIS trial, which is about the beta blockers post-MI with ejection fraction of 40% or above. This was a small kind of late breaker of 150 patients. It's looking about digital consults going to clinicians and to patients, trying to empower them and remind them about the importance of guideline-directed medical therapy for heart failure with good outcome. And the actual consults had different components. One is with clinicians and one more targeting patient education with text messages, and one kind of reminding of the importance to ensure continuity. It was good adherence to guidelines. It was good outcome overall. It was interesting about the practicalities of doing things. It's a small trial, but worth reading to just think about innovations in that territory. I mean, digital interventions in cardiology are growing. And some of them are fancy about diagnostics and monitoring, and some of it probably focused on improved therapies, whether targeting clinicians and patients. It's a small trial, but it was intriguing to me. I don't know what your thoughts are, Derek.
Well, I think this is the future. I know my friend Deepak Katecha at University of Birmingham is doing a Dare to Think study, doing exactly this, where effectively telling the healthcare professionals what to do. And I know my former fellow, and again at University of Birmingham, Mark Thomas, has a company now which will ideally not only tell you, but maybe even prescribe in the future the drugs for the patient. So this is clearly coming, so that we dot the I's and we cross the T's, and we get everybody on the evidence-based therapies. Is that what you think?
Yeah, I think the challenge is going to be, how do we ensure that is still personalized.
Yeah.
I think we're going to continue to refine it to maintain that, but it's a good push forward. You've talked about the Epic card. I'm not going to talk about that. There was a couple of interesting trials going back to deprescribing, and we always had a thing about what do you do for patients who are undergoing non-cardiac surgery a year after they've had their stents? Is interrupting antiplatelet therapy a worry or not? So this was an interesting trial, basically, that telling us that for those who are undergoing non-cardiac surgery after a year of having drug-eluting stent, there was no difference in ischemic events or bleeding when we interrupted the antiplatelet therapy. It's give us reassurance. It's more about so that we don't panic thinking that, do we have to do it or not? So it gives us that flexibility and option. So more of a reassuring trial, really. That I think we probably do that. I think we do that with dual antiplatelet therapy if it's beyond 6 months usually. And I think the monotherapy, we're probably less worried if it's after a year. So what are your thoughts, Derek?
Yeah, to be honest, this is what I've been doing, and it's nice to see someone's shown that that's the right thing to do. I forever get letters from dentists. What should I do? And so, and this is what I've been doing. So it's nice that the evidence has caught up with the eminence.
Yeah, yeah, absolutely. This is another trial looking at the RAS inhibitors, so the renin-angiotensin system inhibitors. Again, same concept. We're usually worried when people undergo surgery whether or not we should stop their ACE inhibitors or their ARBs. And usually we recommend stopping them because we worry about the hypertensive effect and complications. And this is another trial which is basically saying that there was no difference in major post-operative events and complications if whether you stopped or you continued the ACE or the ARBs, which is again another reassuring, probably a trial to just give us a bit of. I guess we assumed that what was the case, but this is a proper trial testing it, whether we have to worry about it so much. And by the look of things, it's not really a major issue, especially when we look at blood pressure and hypertension risk.
Yeah. It's interesting. I know we have the sick days rule for ACE inhibitors and angiotensin receptor blockers in the same way we have with SGLT2s and GLP-1s. And I'd like someone to do the trial for that as well, because here we've got one that suggests that you probably don't need to stop the ACE inhibitors or the angiotensin receptor blockers. My betting is that's also true of the other medications. And I pointed out to my cardiac surgeons the other day that me starting these patients on therapies had a bigger survival benefit than their bypass surgery. Bless their hearts. But it's true. It's absolutely true.
We talked about fine heart. I'm not going to dwell into it. And then there was a few interesting trials about hypertension. This is the GMR2 trial. It was talking about triple therapy, and we've got another one about quad therapy for hypertension. And this is basically looking at using low dose triple therapy for hypertension, comparing it to placebo and active control trials. And the conclusion of this trial was basically that the use of low dose triple single pill, non-adherence to antihypertensives is a big thing, and the less pills the better, and the more we can go in with dual or triple or quadruple. Usually most people with hypertension need to be on at least probably 2 or 3 blood pressure lowering tablets. So this was reassuring that using a single pill seems to work, seems to be safe. There isn't much going to. I mean, the combination included telmisartan and amlodipine or indapamide. So you can pick and choose, I guess, which ones you would like to combine when you're offering the patient. But it was quite reassuring.
Yep, and I think this is exactly where we're going. Combination tablets are the normal now. And I think in the UK, we've always been reluctant to take this on. And I know some of my predecessors here at Birmingham City Hospital led that discussion and saying it wasn't the right thing to do. But for compliance, I think it is the right thing to do. And there are now several studies suggesting that multiple drugs for blood pressure, for cholesterol in single tablets work better.
Absolutely. And I think probably, I think historically it's the cost that was off-putting from actually going down that route. And I wonder, we're having now more and more combined therapies where there was no any extra cost to the additional therapy we're adding. So like in bempedoic acid and ezetimibe, we're not paying anything for ezetimibe and so forth. I'm sure pharma can come up with some combination therapies which doesn't have a huge difference in cost compared to if we use them as separate individual tablets or we do it in combined, given all the benefits that you're saying from having it as a single pill. This went one step higher and then went for quadruple single pill combination therapy versus triple combination therapy. And that's merely people probably with difficult to treat hypertension. And it is interesting. It went down the route of resistant hypertension, as defined in here, randomized the patient to either this single pill with indapamide, perindopril, amlodipine, and bisoprolol, and then a matched placebo, basically. And and the effect was obvious. I mean, it probably is expected, but the outcome was good. And the conclusion is that having 4 antihypertensives was more effective than 3 in patient with resistant hypertension. Tells us probably a lot whether is adherence an issue or is it just having more antihypertensives at lower doses potentially probably would work better. It's a combination probably of both.
Yeah, you're probably right. And, remember strong HF, get all 4 therapies and heart failure in at low dose and titrate upwards. It's exactly the same in hypertension. The days of going full dose of anything have gone.
Yeah. This is an interesting old debate about should we give antihypertensives in the morning or the evening, and is given it in the evening has better outcomes in terms of cardiovascular outcomes and basically the trial, which is called the BED-MED and BED-MED-FRAIL trials, they explored basically, it's a Canadian trial, they explored the use of antihypertensives at different times, whether it is in the morning or evening, and one of them focused on the frail elderly in specific. And basically, the conclusion was the evening administration had no clinical benefits over the morning administration. And there's a meta-analysis also exploring it, bringing all the different trials together as well, bringing the 5 trials. So you've got the BED-MED, and you've got the time trial, and you've got the other trials that were published previously, giving probably a bit of mixed evidence, but the conclusion of when you combine all the trials in this meta-analysis doesn't make a difference. And I guess the ASC guidelines say as well, pick up the time that makes the patient remember most, because non-adherence to antihypertensive is way more important than any added benefit, if there is any, and these trials says there probably no added benefit for the timing.
Yep, brilliant, isn't it?
Straightforward. Yep.
All the things I used to believe there are wrong.
Then we had 4 guidelines published at ASC. You've got the hypertension guidelines updated and published, atrial fibrillation, and the chronic coronary syndrome, which is stable coronary disease, and the peripheral arterial aortic disease. I haven't dwelled on all 4. You probably have to have a look at them, but I've selected about 3 of them to just quickly reflect on what the major things that we need to think about. I think the first one about hypertension is quite comprehensive guidance. It talks about, reminds us what hypertension is about, what the different causes, the secondary causes and the non-secondary, and the primary kind of potential primary underlying causes for hypertension. It talks about the whole complexity of it, whether it's behavioral factors, genetic factors, renal factors, neural mechanisms. So it's quite comprehensive and discusses it at actually quite a lot of detail. But then it introduces this three different types of non-elevated, elevated, and hypertension. And it created a bit of an interesting discussion around is elevated blood pressure, which basically it is saying anybody with a systolic blood pressure, it's an office blood pressure between 120 over 130. So it's less than 140 and above, I guess, 120 and above. And less than the 90. So it creates a new category, which they call elevated blood pressure. And then the whole guidance goes about, do you treat or not treat in the elevated blood pressure? And it seems to talk about you need to risk score those people. And sorry, I've jumped a few slides there. You need to risk score patients with elevated blood pressure to decide if you want to treat or not. So while hypertension, instantly, yes, you need to treat. Whereas elevated blood pressure is you need to do a CVD risk scoring using the score, which is the ASC equivalent of IQ risk, and other scoring systems, unless somebody's got kind of other comorbidities. And then based on that, you decide if you treat or not. So interesting new approach, trying to fine tune the risk estimation. What are your thoughts about this?
Well, it's interesting because the first thing to say is the European Hypertension Society has split off from the ESC. So they're now separate guidance. And whilst this was a meatier guidance than we've had before from the ESC, it's substantially smaller than the European Society of Hypertension guidance. And it's also slightly different. You and I were joking. Our friend Hani Raghi, who's professor of cardiology in Cairo, pointed out that in Arabic, elevated and high blood pressure basically meant the same thing. But it's getting the point. The beginning of risk for blood pressure is with a systolic of 90 and then it rises. Now, you're never going to reduce most of your patients to 90 because they'll get postural hypertension. But this idea of pre-hypertension, particularly in patients that have other risks, high cholesterol, diabetes, obesity, it might be worthwhile thinking about lowering it in that 120 to 130 group. I don't think it's a bad thing. I don't think it's a bad thing at all. And I think, although there were criticisms, in the fellows room, you and I were there, I think it's a pretty good guidance.
Yeah. I guess it makes you think about, whether you need to tighten the blood pressure slightly more to reduce the risk overall. So these kind of the targets that they have in the guidance. So So it talks about the assessment for symptoms or signs of hypertension, of course. If somebody's got systolic hypertension, that's kind of 140 or more. Then it talks about non-elevated. It talks about then it talks about the targets. So the target that they look for is somewhere between 120 and 129 systolic. That's kind of the potential. And optimal, so they call it optimal. If it's actually tolerated. So they try not to drop it too much. The below 120, they're trying to keep it between 120 and 109. Of course, less than 140, but not too low as well. Which is quite interesting. Of course, the consideration for hypotension and elderly is also taken into account.
And it's interesting, you see it there, elderly now is over 85. That's a slip again from 80. So that's not a bad thing. It means that, this ageism of treating people with 75 with less secondary prevention medications, that should go because we know it's beneficial.
Yeah. This is a nice kind of diagram. Just to be honest, it doesn't add much to what we already know. So ESC is an advocate of combination therapy for managing hypertension, unlike our approach where you start with a single therapy and you up titrate and you add another one. They go with dual combination instantly, and they go to triple and add further. So this is kind of summarizes this approach, and then it defines what true resistant hypertension is and what can you do for that. And it talks about what other comorbidities the patient could have, and then how would that change your preference to antihypertensives. So if somebody's got heart failure, if they've got CKD, and the use of different classes of therapies. So if the use of diuretics and what happens if somebody's EGFR is less than 30. So it's quite useful kind of recommendation that worth having a look at without us kind of dwelling into the detail, but worth knowing that there is something there to consider when you're managing patients with hypertension who've got other comorbidities, and probably more efficacious ways to, or effective way to manage it, rather than having way multiple probably visits and reviews. Probably need to plan it and think it through as well.
Yep,
Any
absolutely.
thoughts? Yeah.
No, I think that you've hit the nail on the head. That's exactly what we should do. And it does give us more of a schemata of what we should be doing in these patients.
Yeah. Then we've got the AF guidelines. Again, it is quite thorough, comprehensive guidelines. It talks about the impact of AF, talks about personalized care, talks about patient what to do if somebody's got other comorbidities. I've just picked up a few things. So the first thing I picked up is they've got this new care approach, and the care approach basically, the C stands for comorbidities and risk factor management. So when you're managing AF, it's all going around becoming more cardiorenal metabolic and becoming more kind of comprehensive and person-centered care. So thinking about what comorbidities the patient have, if they've got AF, and managing those risk factors that they have, whether it's lifestyle. There's a lot of emphasis on these guidelines, both the hypertension and also the AF. And the stable coronary disease, emphasis on lifestyle modification. Then the A is all about anticoagulation and risk assessment, and kind of empowering the patients and make the access to anticoagulants much easier. Then the R is all about managing symptoms, whether it is rhythm control or rate control. And then the A is for kind of continuing to follow up and reassess and support the patient. So this is what they call the integrated AF care. As you can see, that patient centricity is becoming more and more a feature of ESC guidelines, which is quite. So we published a piece of a critique of ESC guidelines, I think in 2020, where we've assessed about 5 to 8 different ESC guidelines, and we checked them for patient centricity, and it's quite and it wasn't brilliant. The outcome was that one of the biggest recommendations we made to ESC at that time was you need to do more to make your guidelines more patient centric. And it's quite good to see how a shift has happened since. So in 4 years, ESC guidelines are becoming more and more patient-centric, which is quite refreshing. Any thoughts on that? And the last thing I've got is the CHADS-VASc. I'll talk about it. Anything to add to this one?
So I was very fortunate. I gave several lectures with Greg Lip and with Isabel van Gelder around AF at the meeting, and Isabel wrote this guidance with Deepak Kotecha, and of course Greg, if you move on to the next bit, is the CHADS-VASc. And I think, why are we moving to CHADS-VASc and to personalized care? And the answer is it works. We know that if you treat all the risk factors, and there are lots of studies, that we lower the endpoints for AF, which are often strokes, but also they can be myocardial infarctions, they can be peripheral arterial disease outcomes, or brain hemorrhages. So all of them will reduce your risk. Remember, your HAS-BLED score goes up with your CHADS-VASc score, now the CHADS-VASc. So why CHADS-VASc? So Greg explains it to me in great detail. And ostensibly, if you look at the old days, women had much higher risk with AF. Now, in the latest databases, it's very similar. Men and women have the same risk. The SC bit is confusing. There's women getting an extra point, so you have differential scores. So they'd like to take that out. One size now fits all. CHADS-VASc is for both men and for women, and it works. So we'll see whether it's taken up. We need to get it into all of the MD Calc and all the online calculators. We need, for instance, in the UK, for NICE to take it on board. I think they will. But the bottom line is, I would imagine in 5-10 years' time, we'll be using CHADS-VASc as opposed to CHADS-VASc.
Yep. Just conscious of the time, just moving on. This is the stable coronary disease. I selected mainly the pharmacotherapy section, but I know there was a lot of elements about the diagnosis and especially focusing on non-obstructive coronary artery disease, the ANOCA and the INOCA, and details about the diagnosis and the different types of chest pain and how to kind of navigate that. But I'm not dwelling into it, but it's probably worth looking at it. I don't know if you want to comment on this at
Yeah,
all.
sure.
Yeah.
So our friend VJ Canadian, professor in Newcastle, was involved in this study. And ostensibly, we know about 1 in 5 patients with angina will have ischemia with non-obstructed coronary arteries. It's a real thing. We now have very good guidance about how you diagnose it, how you manage it, and I think it's going to be incredibly useful. Just to mention, one other paper that VJ produced was the much-awaited Seniorita trial, looking at do you intervene or not intervene, or do you do an angiogram or not an angiogram in patients over the age of 75 with non-ST elevation MI. Again, a New England Journal paper with no benefit to intervention, to early angiography, which is quite fascinating, Rani.
Yeah, fantastic. Worth having a look. So I just picked up some of the cardiovascular pharmacological interventions that highlighted in the new kind of what changed, mainly around, again, emphasis, as you can see, about lifestyle changes and exercise interventions. And the anti-anginals, there's a bit of a discussion around that, especially combinations of what not recommended, what recommended. Further emphasis on the use of antithrombotic therapy and lipid lowering. The goal that is set is still less than 1.4 and at least a 50% reduction in LDL cholesterol versus baseline. The combination therapy being pushed of using more and more combination therapy lipid lowering. The use of SGLT2 inhibitors for patients who've got type 2 diabetes is further emphasized. GLP-1 agonist further emphasized in those who don't have diabetes, but also who are overweight, have got obesity, because it's got benefit reducing cardiovascular mortality, MI or stroke, and emphasis on colchicine for use, 0.5 milligrams daily. So these kind of some of the kind of big new bits. Any comments? Do you use colchicine?
Yeah, well, I was a cohort investigator, and I use it. Great paper, by the way, not at the in the papers that we've shown today, but by Paul Ridker, looking at 30 years of risk in women in the New England Journal, showing that HSCRP, LDL, and lipoprotein A are all major risk factors. And the HSCRP is the target for colchicine. It's not funded by the pharmaceutical industry, but the evidence is there. We probably should be using it more, Rani.
Yep. And tend to be very well tolerated. People tend to worry about diarrhea, but at this lower dose, most people don't seem to get any diarrhea. Right, so the last thing I just want to highlight in the last couple of minutes is just to say there is also the obesity and cardiovascular disease consensus statement by the ESC, which is worth having a look at and reading. It talks about the impact of obesity on cardiovascular system, whether it is increasing the cardiovascular risk factors, whether it is atherosclerosis, heart failure, valvular disease, arrhythmias, and it's quite a good kind of reminder of the way we're moving, which is the cardiorenal metabolic management of our cardiology patients. And that is the way. And I'm not going to dwell too much into it, but it talks about the lifestyle intervention and what impact it has on the different risk factors, whether it is cholesterol, whether it is blood pressure, and also on weight. The pharmacological interventions, I know some of them we don't use anymore, but some we do. And then, of course, the surgical intervention. But it also dwells into the impacts of obesity and on heart failure, different types of heart failure. It talks about obesity and AF, and it talks about the use of antithrombotic in patient with obesity as well. So these are quite interesting and exciting reads, conscious of the time. Maybe some comments if you've got anything there, Derek.
Yeah, no. Yeah, I think you've hit the nail on the head. Interestingly, the one bit of data that we haven't mentioned, as I presented the data for the UK use of GLP-1s in patients with diabetes and coronary disease. And if I just try and share for a second, guess what? Let me see if that works. guess what? We found that these GLP-1 agonists, you get bigger reduction in MACE, non-fatal MI, non-fatal stroke in grey with the use of GLP-1s than DPP-4s and basal insulin. So that is clearly the direction of travel. And I think, let's be honest about it, that's where we're going now, I think, Rani.
Right. I think people put in some questions. Sorry, I was while presenting it in Indian. Why not to use spironolactone for HFpEF patients? Loop diuretics, SGLT2 inhibitors, and spironolactone. I think
maybe I'll answer that. If you go back to the earlier part of the lecture, the TOPCAT study with spironolactone and exactly that group was negative. We think it was a flawed study. If you take out certain countries, it becomes a positive study. The Germans are repeating it with Spirit, but that isn't published yet. So it's not licensed for HFpEF. It's not recommended by NICE. But the truth is that I think it probably will be useful, but we need to prove that. In the interim, our friends at Bayer have shown that finerenone works. They'll be seeking a license specifically for that. And so I think it will be recommended. Secondly, the question about itoverstat and ezetimibe. Again, go and look at the Sweetheart study that was in the European Heart Journal just a couple of weeks ago, presented by Koshray and others at the European Society of Cardiology. And ostensibly, it backs up what we put in our European Heart Journal paper from a couple of years ago, that early use of ezetimibe is useful. We give it to everybody post-infarct because there is no too low in LDL cholesterol. It costs £10 a year, and we're much more likely early to achieve the levels, as per Sweetheart, that result in that reduction in MACE. Is that fair, Rani?
Absolutely, absolutely. So, right, we've come to an end. It's been a pleasure having you, Derek, with us. Thank you so much for coming to support this session. It's been absolutely brilliant. Thank you, everybody, for attending. We will be posting this on YouTube for people to watch. I know that some people registered, but they couldn't make it. Somebody's got their hands up. I can't open the mic for you. I'm really sorry,
I think,
Mohammed.
Yeah, Mohammed's asking, it's not NICE recommended yet with this ezetimibe. I can tell you, if you're in England, NHS England, Helen Williams, I'm sure you all know Helen, is absolutely enthusiastic about ezetimibe usage. Go and look at her publications. We very much, NHS England, know that this is cost effective. It will save money as well as strokes, heart attacks, and lives. So email Helen, but the bottom line is, please give ezetimibe up front. It works. And the paper from Sweetheart shows that you reduce MACE events.
Yeah, I agree, and I support that. And I'd say it doesn't say not to do it either. So I think what you need to remember is that NICE might have said, yes, go for it over 80, but you'll have, if you have a good justification, it's guidance first, and if it has good justification for doing it, which we do, there's no reason why not. But I think there would be many scenarios where it's absolutely the wisest thing to do, probably.
And interestingly, Joe Mills in Liverpool backs us up again, and he led that committee. So 100%, I think this is what we should do. And then check it again at 2 months. Don't wait for 3 months, less than 2 months, and add in therapies, because that's what they did in Sweetheart, and it works.
Yeah, fantastic. Okay, thank you so much, Derek, for enriching our discussion and contributing to it massively. Lovely to have you as always. And thanks to all those colleagues who attended, and we look forward to seeing you for another session. Thank you.